Hi, my name is Dr. Toby Moma. I'm a family physician, assistant professor at the University of Mississippi Medical Center, and it's a joy to ask you to join us on our show, Health and Wellness with Dr. Toby. This week, we have a great guest. His name is Dr. Femi Ogundeji. He's an addiction psychiatrist at the Brentwood Hospital of Psychiatry in Shreveport, Louisiana. Been with them for 6 years, trained at the University of Ilorin, Nigeria, Drexel University for his psychiatry residency, and then went on to do 2 years of addiction psychiatry. He's one of the few addictionologists in the state of Louisiana. He's going to be sharing his experience treating gambling, treating sex addiction, treating cocaine abuse, treating marijuana, ADHD, stimulant abuse, treating children, adults, pregnant women. He has a multi-specialty experience, and you don't want to miss it. Look forward to seeing you on the show. Jesus is Lord. God bless you. My name again, Dr. Toby Moma, your host on Health and Wellness with Dr. Toby. God bless you. Hi, I'm Dr. Toby Moma, your host on Health and Wellness. Don't touch that dial. We have a great show with Dr. Femi Ogundeji. Dr. Ogundeji is an addiction psychiatrist, works at the Brentwood Specialist Hospital in Shreveport, Louisiana, trained at Drexel University for his residency in psychiatry. Medical school was at the University of Ilorin, Nigeria, and he did his fellowship at a branch of the Albert Einstein Hospital in Bronx, Lebanon. He's here with us. He also got his MPH from the University of Alabama, Birmingham. He's been in Louisiana now for 6 years, working in the northwest part of Louisiana, and he has seen a lot of addiction stories. Let's just start with that. Tell us a bit about the kind of patients you see, because you're one of the few addiction psychiatrists in the state of Louisiana. Maybe there's other two or three, maybe.
I've actually made maybe one since I've been
Right.
here.
So, what kind of patients come to your practice?
Well, with my practice, I do both inpatient and outpatient
Outpatient.
services because with addiction, the first process is be medically detox, where you'll be supervised in the hospital while we get the medication out of your body. But we have different mix of patients. Some who have reached their rock bottom and they've lost everything and they want to get help. We see some who are mandated by the legal system to come. And we see some who are sent from the hospital because they're having some complications like liver cirrhosis, hepatitis, pancreatitis, and all that. We see women, we see men. At times we feel addiction is more of a problem of men. One of my patients yesterday was actually pointing out to me that we have more women on admission than men seeking help at this particular time. And addiction, unfortunately, is no respecter of age, sex, race. I see all races. I see college professors. I see doctors. I see homeless. I see old. I see young. I've treated kids as early as 15, 16 who are already using IV drugs. And I've seen 85 is my oldest I've actually treated for addiction. I see people in their 70s. So it cuts across the rich, the poor,
Wow.
employed and unemployed.
What's the most common drug of substance abuse you see in your practice?
At this time, alcohol still ranks first.
Okay.
And most people, the problem is that they don't see it as a problem at the time they are starting because it's readily available in the grocery store, liquor store. They are paying their money for it. So they don't see it as a substance until they start having complications. People will come in with black eye and they won't know how they got black eye. We say it's blacking out. When you drink to a point, your brain is dead, but you're physically awake. You do things you don't remember. That's when people come in, falling into gutters, being stabbed or being attacked on the street. So alcohol seems to be the number one. Then opioid is next to it.
If my viewer was trying to tell if her husband had an alcohol problem, how many glasses or how many, I don't know if they call it uh, shots of alcohol, how do you quantify an alcoholic in 2020?
Alcohol
Because there's a
varies
16
on what you
ounce.
drink.
there's,
A
there's,
12 can beer is considered the standard. A 12 ounce of beer is equivalent to a glass of wine and is equivalent to a shot of liquor. The double proof, a little short of that. So we can calculate how much you drink. Healthy drinking for women is drinking less than 4 or less of that per week, and for men, I think it's 7.
okay.
5, no more than 5 at a sitting for a man, and no more than 3 at a sitting for a woman.
So if a man takes more than 7 to 14 in a week, he may be dependent or
Dependent.
abusive.
Yes, and then there are other things we begin to look into. Are you beginning to spend more time on the alcohol? I've even tried to cut down. You wake up in the morning looking for alcohol or drugs as an eye opener. Can you not function except you have something to drink? Some people, they can't eat in the morning until they have alcohol because they will just keep throwing up what they are drinking. Is it beginning to affect your daily life? Are you operating machines or driving under the influence of alcohol? Those are some of the factors we look into, rather than I don't drink to the point of passing out, but as they become things affecting your daily life.
I know in my residency there's something we call the cage and there's something we
Cage,
call the
the
siwa.
work, yes.
Siwa.
The, the
I know.
cage question is just a screening any provider as a nurse practitioner, um, a doctor can use at every visit, whether you're an ophthalmologist, you are a psychiatrist or internist, just to assess to see if somebody has alcohol problems. The cage, the C is asking, have you ever tried to cut down on your drinking? Do you get annoyed or angry when family members talk
That's the
about
A,
A?
right?
And then the G, do you feel guilty? And the E is the eye opener. So if you score 2 out of 4, you need further evaluation for drinking. Why the CY is where we use at the time of assessing somebody who come in to get help for alcohol detox, to rate the severity of their withdrawals, because some people might need ICU treatment because on their score on that, while some people can do well in detox, some people can do well in rehabilitation based on what their CY score is.
There are people who say I'm a functional alcoholic. Why do I need to stop? What would you say to those people? I get my job done. I provide for my family. Why should you badger me about not drinking? I drink 10 cans of 12-ounce beer, every weekend, a day.
I hear that a lot from people saying, oh, I'm a functional alcoholic, I can hold my job, I can drive, I can do this, but I drink this much. One of the best way I convince such people is through lab work. Because there's nothing you will say to them, they will tell you, I've been drinking for 20 years, because they've developed tolerance to it. Their body will take it, their blood alcohol level might be 400. But when we start seeing their lab result, you find out that lipase is high, which is already causing injury to their pancreas, their liver enzymes are elevated. When they see numbers and like mine is like 10 times above normal, some of them will be willing to cut back or receive treatment for that. But that's one of the main problems. People are functional alcoholics will tell you, I can function with it.
What's your strategy for alcoholics, apart from psychology, which we know your psychologists do psychotherapy? In terms of medications, what are your go-tos, and how do you, like you said, you don't want to withdraw suddenly because
Yes.
there's a risk of increased mortality in an alcoholic now. And
So the first stage in treatment is the detoxification, where we bring them into the hospital or can be done on the outside, which I don't usually do it to give patient the medication, because if you're already an alcoholic, I don't trust you enough, because you might go and drink with those medication. But in the hospital, we give them medication that acts on the same part of the brain alcohol acts on. And the way I explain to them is that you don't wake up one day and start drinking a case of beer. You start with one, it becomes two, three, four. So I'll give them the analogy as if you're standing in front of a staircase going to the third floor, and you begin to climb up gradually. That's the way alcohol is. You start with 1 glass, 2 glass, 1 bottle, 4 bottles, 5 bottles, until you get, and then you want to stop abruptly. It's like jumping down from the third floor. You can hit your head on the floor, you can have a fracture, you can bleed and all that. So at the end of the day, I will tell them we give them something that acts like alcohol on the brain, that acts on the same part of the brain that alcohol acts, so that they won't be sick, they won't throw their body into problem. And every day we slowly reduce the dose. So it will be as if they are climbing the staircase down until you get to the ground floor. So after we successfully detox you with no seizures, with no complication, monitoring your electrolytes, your liver enzymes and all that, then we can talk about the rehabilitation phase. That's the most important part. People do detox and think they are being cured. Alcohol or addiction is a chronic disease, the way we treat hypertension, HIV, diabetes, that we don't cure them, but people live with them and have a better control. So likewise, alcohol too, you can control it. And there are FDA approved medications. There are 3 classes of medication that are in the market that can help people maintain sobriety. One of them, I might mention the name naltrexone, is something you give to people that when they take it, blocks that part of the brain that just want to give them the urge to drink. And with time, people can cut back on their drinking. And I've seen people who had good success with it. There's an injection form. And the last one, which I don't usually prescribe, except if you've tried everything, is the anti-abuse that you can give to somebody who is willing and motivated. This works especially for people who have genetic predisposition to be an alcoholic.
Okay.
Grandparent was alcoholic, father was alcoholic, and it runs in their family so strongly. No matter what they do, after a few days they go back. When they have good support systems, maybe a spouse, a family member who monitors that they take the medication, they can't drink alcohol because they will be sick. So it's a form of punishment, and over time, they just the habit goes away.
And you use acamprosate too?
Yes, that's the third one.
Okay.
Acamprosate is the third one. Usually, this middle one is not good for people who have liver damage. You find that most people have drank for a long period of time with liver cirrhosis will prefer to do the acamprosate on them because it goes through the kidney. And we check the kidney and monitor them. And we've had good success with that.
Wow. Let's shift gear now to opioids. You've described in detail what you do for your alcohol dependent patient, which is your number one substance abuse. Now, the number 2 you said was opioids.
Yes.
What do you do in your practice for opioid dependent
Yes.
patients?
With opioid, the first thing when they come into treatment is to detoxify them so that we can have a baseline. People use opioid because they had a dental procedure 15 years ago, and I've seen somebody who said she was taking it as prescribed after a cesarean session, and then she read the bottle again and said, do not take more than prescribed. And out of curiosity, she took more than prescribed to see how she feels, and then she liked the way she feels, and that was how she got hooked on that. And you see people have chronic pain who legitimately have chronic pain, don't go to see doctor, or because they have addiction to other problems, doctors are worried about prescribing for them. So we first safely detox such patients or such clients. There are 3 different categories of medication we can use to safely get them off the opioid they were using. One is using methadone, buprenorphine, and clonidine, depending on their choice. And after we detox, then we can now set goals. How tolerable is your back pain? We try something else. Does this work? Maybe some of them don't even have any pain anymore. Like, oh, I always have pain. The 3rd day I stopped taking my pills. Then we explain to them it's more of the withdrawal pains. Now you've gone through that. You can live your life without pain. And some people, because of genetic predisposition or how they've been using the pain, it's better safe, especially people use heroin, IV drugs, and all that. We can refer them to safer alternatives. Things like the methadone program. It's safe. At least they are not sharing needles. They can monitor them. They get them counseling, the buprenorphine program. And now we have the opioid blocker, Vivitrol, that you can get the injection once a month. And anytime you use pain pill, you become sick because it won't really work. And with time, people just stop using. And we do this with counseling and vocational rehabilitation as well, because you can't just treat them without getting them more gainfully employed, because a lot have just been on the street for years doing nothing.
Talk to my viewers about the new, is it called CAPS fentanyl? The new one.
These are medication people are bringing from China. They claim most of it come from China or the dark Google. It's more potent than the regular medication, and that has caused a surge in the opioid death. A lot of people have accidentally overdosed and died on it. Not many people are actually seeking out for that fentanyl, but most people sell heroin to them and mixing that with it, one, to get a better high so that people can get hooked on it. And one of the problems we have is if you've been using opioid for a long period of time, you tend to have tolerance to it. But when you go to treatment and you are off it, your tolerance goes down. And after some time, these people relapse and go back to the amount they are using, and that causes respiratory depression, and people die. Unfortunately, most lab tests will not pick them up except if you send them for specific lab. You just know that, oh, we don't know why this person died.
Tell my viewers, what would you do in a pregnant woman who is addicted to not heroin, cocaine now, but opioids? Maybe they gave her opioids when she was pregnant the first time for C-section and she continued on it. Now she's pregnant. Is there a danger that that baby can develop opioid withdrawal complications?
Yes. With most of the drug, whether cocaine, alcohol, they all carry risk in pregnancy. And
Do you see pregnant patients?
yes, I do.
So give us your experience.
Okay, with pregnant patients, one of the things we always encourage them when they come, because they are worried, their main goal is to be able to stay sober during pregnancy so that social services will not get involved with the kids, taking their kids away from them if they test positive. We've safely detoxed pregnant women. We do it in my program. We just have to monitor them closely and do a much more slower taper from them, because the drug they are using goes through the placenta, gets through the baby. So when they are sick and they are withdrawing, the baby is withdrawing. And one thing that is very common in women who use drug is that if they use drug heavily, it affects their menstrual cycle.
Oh, right.
So many of them will not menstruate for 3 months and they think it's just their drug, they don't care. And the few that will have morning sickness, they will think it's withdrawals and they will continue to use more drug until maybe their stomach start bulging. We see most of them in their second trimester trying to get off benzos. And most of these things have effect on the maturing baby, the brain and all that. So we try to help them, and we've had very good success. And there are programs now in Louisiana that can keep a woman in rehab as long as they are pregnant so that they won't be tempted into going back to the streets to use drugs. And methadone program, if it's opiate and you don't want to stay, it's better to get a steady and safe dose that can be monitored. That will be good, rather than you use 10 bags of heroin today, you use 2 tomorrow because you don't have money and you go through withdrawals. The baby might die going through those fluctuations in the level of opiates.
Do you believe everybody should be treated equally for opioid dependency, irrespective of their age? What I mean is, at times you hear people say, oh, this doctor gave narcotics to a 75-year-old woman. That is so horrible. But if you give it to a 45-year-old, nobody blinks an eye. I'm like, are we trying to deal with the source, or should we be defining the people who receive opioids? What's your thought?
I think there should be standard care that cut across every age, because the 75-year-old woman was 45 some years ago. I've seen people who had back injury and they're on the same dose of opiate for almost 30 years. They just go, they don't abuse drugs, their urine is clean, the doctor will just keep prescribing them. It should be a standard care where you reassess the patient for the need, even if it's every 3 to 6 months. That we've been on this medication, let's see the progress you've made, let's look at alternatives, let's see at reducing the dose. If you take it 5 times a day, let's go down to 4 and see how your body adjusts to that. Or let's do MRI, let's do imaging to see. And what most of us are worried, oh, you're giving a 70-year-old woman benzo, she'll break her hip and she will recover from it. But if it's a 20-year-old, we don't worry about that. So I think people are being partial and maybe looking at age to prescribe. But
what's your third most common drug of choice in in terms of those who come to your clinic?
Benzos.
Benzos. Okay. How do you do that in the clinic or outpatient or detox? It's the same strategy.
The same strategy. Benzos use, if you can do outpatient treatment, taping. If the patient is not on a short-acting benzos that can cause seizures when they withdraw, you can first convert them to a much longer acting. And then every month or every other month, you go down by 10 to 15% of the total pills you give them. And some people just want to get off it acutely, especially if they are pregnant or they've had a DUI or they have had an accident under their influence. Is an eye opener. But with benzos, I think the doctors are the one who creates the problems. Most anxiety, yeah, people just come in for anxiety, or maybe they have acute stress problem. Somebody died, a pet died, and they are worried, and the doctor just prescribe, and it becomes something 1 month to 6 months to 2 years. I always tell my patient that you have anxiety, I understand, but with anxiety, it's something you don't have control over. It comes at any time. So one of the things that will help is therapy, how to be able to deal with it better. The benzos is not helping with your anxiety, it's only numbing your feelings at that time. When it wears off, you're most likely going to where you are, and you're not dealing with it. So if you're going to do benzo, it's for a short period of time. I won't give you refills until you can call me that you've gotten a therapist and you've started your counseling. And when you've made progress with your counseling, we start reducing it, the quantity. Then we go to as needed. I can only give you like 10 pills a month. And you find that they most likely like it that way. And the other non-controlled substances that can help with anxiety, but most patients have either tried the antis, Xanax or somebody, and the feeling is different. And if they don't get that feeling from,
They don't feel they're working.
They don't, they just tell you this is not working.
How about ADHD medicine? Is that on the upsurge? Or is
Yes,
it on
it's under the stimulant. It's on the upsurge. The criteria to get ADHD medication is so low. I've seen people come in, and I will tell you ADHD is for you to, it's something that affects your functioning, either in school or your ability to walk. You see a 60-year-old, 70-year-old who is on disability, not working, not in school. I'm like, what do you want to use the ADHD medication for? You're not reading, you're not taking exams. And at the end of the day, I found out that people are using it for weight loss. Rather than, after you struggle and struggle, let's try non-controlled substance for your ADHD. And if they insist, I'll send them for psychological testing. But those who really need it, they don't get it because their doctors are worried about people who abuse it. So there are things you could do. One, there are long-acting and short-acting ADHD medication. If you take a family history when you're evaluating a patient and there's a chance there's a higher risk of substance abuse in the family, you rather go with the long-acting because that doesn't just cause a peak, because the immediate release gets into the system, gives them a high, and that predisposes them from abusing it. And it's so common in high school kids who are prescribed, might not like it, they sell it to other kids in school.
And for those who don't know what we're talking about, stimulants are like Ritalin, Adderall, Vyvanse, what's the other one? Was it Foscana?
Yes.
There's quite a few of them in the market, so keep an eye on that in terms of your kids. How about the big ones that, crack, cocaine? Is there a solution or you just stop it?
With crack cocaine, it causes more damage when you're getting high on it because it raises everything up. That's why you find out that people have cardiac arrest. You find out that people have seizures, they bleed into their brain. Because
so that one you just stop. There's no tapering.
There is no tapering. You stop, but usually at times in a controlled environment because you have some behavioral changes with it. And most people come into the hospital with meth, crack. Some of them already not slept for a week. They are beginning to hallucinate, see things that are not there, hear voices of people not there. Their mind is playing games with them, and they just need to stay away from it. And we check, and at times, because it could affect the kidneys as well, you see them coming with high creatinine values.
Same thing with marijuana.
Marijuana, yes, and marijuana has one funny syndrome,
Oh, really?
which is called marijuana-induced hyperemesis. You just found out that after something, they just keep throwing up and nothing. You give them Zofran, you give them,
Right.
it doesn't work. And what works is all shower. We just leave the shower for them until they can pass through that phase.
Oh, really?
And so drug react to people differently. And with the advent of things like mojo synthetic marijuana, we see people having seizures, blood clot problems, and
Wow. How do you handle the stress of this life of addiction psychiatry? Because you hear a lot of stories.
please.
So you have to shield yourself from the trauma that you're hearing, and you don't want to affect yourself in terms of, become cynical and not responsive to people's hurts and pains.
I think I do. One of the things that's really helped is being an empathic listener.
Mm.
I just don't want to look at you that this is a drug addict or somebody who is using drug. I want to find out what happened that led you to this point. How can we unwork some of these things? And I'm always candid with them. Some that I see that has made progress, I'll do this, do that. And some of them are like, I will see you again. They were like, you will never see me. This is the problem. We've not addressed the main reason.
Okay.
And you're going back to the outside, and they will come back and like, I'm back. I'm like, I know, but the day you were leaving, I was worried. And I pray you won't overdose, and we'll walk through the whole process. And I just don't get, I've never used drugs. Some of them would tell me at the acute point when they're withdrawing so bad and want more and more. And like, your vital signs is going that you can't take more of this. Like, you told me you've never drank, how do you know it, how it feels? This was like, I've walked, I've read, I've walked with people, I listen to people, I know how this will pass. Let's just do this. And at the end of the day, some of them like, after they feel better, thank you, you didn't give me more. I was just craving at that time.
Mm-hmm. Well, we've been talking with Dr. Ogundeji, and I want you to get in touch with him if you have a loved one. We are going to put the number on the screen, the address you can call, and, do they need a referral, or do they just call?
No, we have an intake where
Okay.
they call, and
So if you call that number, somebody will take your call and make available how you can reach Dr. Ogundeji. He's in Shreveport, and I know those of you in the northeast part, it's like 45 minutes to an hour. You will have an empathic listener, and he's an addiction psychiatrist, one of the few in the state of Louisiana. Take advantage of this resource, and not just a psychiatrist, addiction psychiatrist, but he's also a Christian. He knows Jesus. We'll see you next time and continue our discussion with Dr. Ogundeji. God bless you. Jesus is Lord. Amen.
Amen.